Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 356 of our pharmacotherapy series, which majors in asthma. The next case reads, STK, a 12-year-old girl with severe persistent asthma, has not been well controlled on mometasone 220 micrograms, marketed as NCLEX, 1 inhalation daily. She admits to using it only when she feels as if she needs it, and uses as needed inhaled albuterol metered dose inhaler 5 or 6 times every day. When her symptoms worsen, she uses her breathing machine, i.e. a nebulizer, at home. STK awakens most nights with wheezing. She has been hospitalized 4 times in the last 2 years and has required bursts of prednisone with increasing frequency. STK has missed many days of school in the past year and has withdrawn from physical education classes and her extracurricular sports activity after school. Her parents are concerned about her increased use of prednisone now that she is approaching puberty. STK is just finishing a 2-week course of prednisone 20 mg per day and has a round facies appearance typical of chronic oral corticosteroid use. On physical examination, STK has diffuse expiratory wheezes, and pulmonary function testing reveals significant reversibility. Her forced expiratory volume in 1 second is only 60% predicted before use of albuterol in the physician's office and improves to 75% predicted 15 minutes after use of the short-acting inhaled beta-2 agonist. So my question to you is, what actions are needed to improve STK's care? Because STK is suffering needlessly and requiring frequent systemic corticosteroids, all efforts must be made to optimize other therapies and to minimize systemic corticosteroid toxicities. Although STK is receiving an inhaled corticosteroid, she admits to poor adherence. Therefore, with her severe persistent asthma, she initially needs higher dose inhaled corticosteroid therapy. Per EPR3, she should also receive a long-acting inhaled beta-2 agonist. Although short bursts of prednisone, e.g., 40 mg per day for 3 days, are very helpful occasionally, frequent short courses often indicate the need to optimize other therapies. Some patients require courses of 1 to 2 weeks. STK is requiring longer frequent bursts and is showing signs of adverse effects. Obviously, STK and her parents also need a concerted and persistent effort in patient education as a partnership. Refer to Patient Education and Outcomes sections. Inhaled corticosteroid are chemically modified to maximize topical effectiveness while minimizing systemic toxicities. EPR3 compares the dosages of inhaled corticosteroid products. These differences in dosages, that is, low, medium, and high, reflect differences among inhaled corticosteroid in receptor binding affinity and topical potency. There are also differences among these agents in oral bioavailability, i.e., absorption of drug that is swallowed after inhalation, and systemic availability via absorption from the lungs. Of these two variables, absorption from the lungs is the most likely contributor to possible hypothalamic pituitary adrenal, abbreviated as HPA, suppression or other systemic effects. Fortunately, the total absorption has not been shown to be clinically important, except at the higher recommended dosages. Although the various inhaled corticosteroid are not equipotent on a microgram per microgram basis, major differences in efficacy or adverse effects are not firmly established. For patients with severe persistent asthma, a logical choice would be a high-potency agent that would allow for a minimum number of inhalations per day, potentially improving treatment adherence. Furthermore, the delivery system used affects pulmonary deposition, but each available delivery system has established efficacy if used correctly. The differences among the various dry powder inhalers are discussed later in this chapter. Addition of a spacer device to a metered dose inhaler also enhances pulmonary deposition. In very high dosages, the equivalent of 1,600 micrograms per day of beclomethasone dipropionate, all inhaled corticosteroid produce some degree of hypothalamic pituitary adrenal axis suppression. The clinical significance of this suppression has yet to be firmly established. Although low to moderate dosages of inhaled corticosteroid are accepted as being quite safe, very high dosages continue to be scrutinized regarding the potential adverse effects. Clearly, for patients who require high dosages for optimal control of asthma, the benefits of therapy with these agents far outweigh the risks. A possible association between prolonged, very high dosages of inhaled corticosteroid and cataracts and glaucoma has been reported. EPR3 has summarized research that has allayed concerns regarding use of ICS therapy and growth suppression in children, i.e., the decrease in growth velocity is small and not progressive, and appears to be quite minimal. My next question to you reads, how should STK be managed? In the treatment of STK, most clinicians would begin with a short course, e.g., 1 week, of systemic corticosteroids to maximally improve her pulmonary function. This approach is consistent with EPR3, which recommends gaining quick control. Using short-course systemic therapy is logical because it is inexpensive, efficacious, and associated with low risk. While gaining quick control with a short course of oral corticosteroids, it is logical to start inhaled corticosteroid in many patients at a low to moderate dosage. The evidence that inhaled corticosteroid are highly effective in persistent asthma is unequivocal. Patients in this category who consistently take inhaled corticosteroid are at a lower risk of hospitalization and death, and one study found an increased risk of death after discontinuation of inhaled corticosteroid compared with patients who remained on these drugs. Inhaled corticosteroid therapy should be initiated concomitantly with a short course of systemic corticosteroid therapy. Patient education at this time may have greater effectiveness because some patients are more attentive after having just experienced an exacerbation, and they know that change is needed to improve their health. Similar to adults, intensification of therapy with increasing the inhaled corticosteroid dose, adding montelukast, or adding a long-acting inhaled beta-2 agonist was found to be successful in pediatric patients, with the long-acting inhaled beta-2 agonist being the most likely addition to be beneficial. Because STK's asthma is classified as severe persistent, it is reasonable to start her on a moderate to high dosage of an inhaled corticosteroid in combination with a long-acting inhaled beta-2 agonist. More aggressive therapy initially is especially important in STK because of her 4 hospitalizations in the last 2 years. In partnership with STK and her parents, her preference should be determined as to the delivery method, i.e., discuss options with her regarding breath-activated devices or metered dose inhaler and spacer, including which spacer. Ideally, the clinician should recognize her emerging independence as a 12-year-old and talk with her alone and then with her parents. After STK is stabilized for 3 months, attempts should be made to slowly decrease the inhaled corticosteroid dosage every 3 months until the lowest effective dosage is achieved. Administration of the total daily inhaled corticosteroid dose is preferred twice daily or, in many patients with mild persistent to moderate persistent asthma, once daily. Because adherence is a major determinant of success or failure with inhaled corticosteroid and other therapies, simplified regimens and continued patient education and contact are essential. Because STK is 12 years old, what options are appropriate to minimize the inhaled corticosteroid dosage, realizing that aggressive therapy is needed? What are the risks associated with long-acting inhaled beta-2 agonists? Clinicians should monitor for which local side effects in STK with inhaled corticosteroid therapy. Long-acting inhaled beta-2 agonists have been very successful in prevention of stepping up the dose of ICS while markedly enhancing overall asthma control, and this fact is reflected in EPR3. A reasonable therapeutic option for STK would be the combination of fluticasone 250 mcg and salmeterol 50 mcg via discus, marketed as Advair 250/50, 1 inhalation twice daily. The budesonide co-formulated with formoterol, marketed as Symbicort, combination inhaler, 160/4.5 micrograms dosed at 2 inhalations twice daily. The mometasone co-formulated with formoterol, marketed as Delera, combination inhaler, 100/5 micrograms dosed at 2 inhalations twice daily. Or the fluticasone furoate co-formulated with vilanterol, marketed as Breo Ellipta, combination inhaler, 200/25 micrograms dosed at 1 inhalation once daily. STK should be re-evaluated in 2 weeks. The plan is to step down the dose of fluticasone after excellent asthma control is achieved. STK's parents recently discovered an article in a national newspaper that addressed concerns of using long-acting inhaled beta-2 agonists because of an increased risk of death. STK's parents have called and left a message for the clinician. What would be important information to share with her family regarding this issue? What other side effects should STK and her family be aware of? Several randomized trials for more than a decade have demonstrated that long-acting inhaled beta-2 agonists have minimal adverse effects, e.g., tachycardia, tremor. Although there are limited data, based primarily on one study, called SMART, there may be a very small increased risk of asthma-related death and asthma exacerbation in patients receiving long-acting inhaled beta-2 agonists. This small risk is likely attributable to patients receiving long-acting inhaled beta-2 agonists without concomitant inhaled corticosteroid. In fact, EPR3 recommends against the use of long-acting inhaled beta-2 agonists as monotherapy for long-term control of persistent asthma. Smart data suggested that Black patients may be at greater risk, but much more study is needed to confirm these data. Long-acting inhaled beta-2 agonist therapy should only be used in combination with inhaled corticosteroid in patients with asthma. Both national and international asthma guidelines clearly state that combination inhaled corticosteroid long-acting inhaled beta-2 agonist therapy for asthma is safe and effective. EPR3 suggests giving equal consideration to a moderate dose of inhaled corticosteroid alone or low-dose inhaled corticosteroid combined with long-acting inhaled beta-2 agonist for patients with moderate persistent asthma. In 2010, the U.S. Food and Drug Administration, FDA, offered recommendations regarding the use of long-acting inhaled beta-2 agonist in patients with asthma, including always using combination products, inhaled corticosteroid long-acting inhaled beta-2 agonist versus two single-agent products to help ensure long-acting inhaled beta-2 agonist are never used alone in asthma patients. In response to the FDA, editorials by EPR3 members and others question some aspects of the FDA recommendations. For STK, who has severe persistent asthma, inhaled corticosteroid long-acting inhaled beta-2 agonist combination therapy is preferred. After being adherent to her new therapy, fluticasone 250 micrograms co-formulated with salmeterol 50 micrograms twice daily, for 1 month, STK's asthma control has markedly improved. She required no accident and emergency department visits or hospitalizations, was sleeping through the night, and began to exercise again. Her personal best peak expiratory flow was 320 liters per minute, and she was staying in her green zone, 260 to 320 liters per minute, requiring as needed albuterol no more than once per week. After 2 more months, STK continues to do well. Although STK clearly needs long-term inhaled corticosteroid therapy, after 3 months of excellent response, her clinician is now ready to step down from high-dose fluticasone. What is a prudent approach to dosage reduction? EPR3 suggests stepping down the dose at a rate of 25% to 50% every 3 months to the lowest dose that maintains control. A step down to fluticasone 100 micrograms co-formulated with salmeterol 50 micrograms, marketed as Advair 100/50, twice daily would be a reasonable reduction in therapy for STK if a single inhaled corticosteroid product had been started in STK initially, e.g., budesonide, beclomethasone, fluticasone. The dosage reduction would normally proceed at a slower pace. However, fluticasone 100 micrograms twice daily, especially in combination with salmeterol, will likely be an adequate dose for STK after STK's dose of fluticasone was stepped down to 200 micrograms per day. She started requiring only slightly more as needed albuterol, but still was symptom-free most days. Another consideration for STK is that recent international evidence-based guidelines, Global Initiative for Asthma abbreviated as GINA, suggest an alternative approach for patients at risk of severe exacerbations. Patients receiving low-dose inhaled corticosteroid combined with formoterol may be instructed to not only use their routine twice-daily scheduled doses, but also use the same combination for, as needed, doses for quick relief instead of as needed albuterol. Although this approach is not commonly used in the USA, it is an option per global initiative for asthma. If symptoms recur during step-down, what management could possibly facilitate dosage reduction of the inhaled corticosteroid in STK? During follow-up evaluations, clinicians should carefully investigate factors that may contribute to poor asthma control, including exposure to inhalant allergens, indoor or outdoor irritants, medications, and tobacco smoke. Second-hand smoke exposure has been demonstrated to reduce the benefit of inhaled corticosteroid in children and necessitate step-up therapy, and asthma patients who smoke have reduced response to inhaled corticosteroid therapy. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 357.